Hello, my colleagues. Let's start our seventh session in mixed Viva cases. Before I start, I'd like to give you two advices according to yesterday feedback session. Number one, listen carefully for the examiner for the history. It is very critical. Why? If the examiner give you something in the history, he will not repeat. If you lose it within inside the exam, it will be your mistake. Very critical according to age and to history. Either this is acute or chronic or something related to a congenital. Very critical. Number two, start scrolling. Take at least 5 seconds in all examination. But in MRI and CT, it is allowed to 10 seconds. Okay, have a look and then survey. Where is the maximum? Ah, doctor, this is the site of pathology. The fruits is here. So start talking about here. This is very important. Don't talk too much about about something other than the pathology. Why? This is an exam. This is not a reporting session. What I mean by this? The examiner bring one exam and want from you to pick up something. Very definitely. He didn't want from you all the side finding, like if you find something in the eye, in the nose, in the turbinate, in no, no, no. First of all, concentrate so much on the expected pathology. Second, only exclude the related negatives. Please, please, most of you yesterday excluding if all the negatives. This is not acceptable. Third, if I give you a CT and then I give you an MRI, don't repeat what you said in CT. Tell me, doctor, this is confirm the finding that we saw in CT. Plus add the additional information that you see in MRI. Like, doctor, the lesion showed moderate restriction. Doctor, it show more infiltration to the bone, to the skull base. Okay, give me only the additional information. Why? Really, too much verbosity is boring. Okay, I'm just telling you some advices for your benefits. Okay, my colleague, this is very important. The style, your style inside the exam, is very important. Half of the evaluation about your style, about your person. Okay, let's start our first candidate. Hello,
Yes, I'm ready.
could you request control please?
Yes. Just a
65,
moment.
65-year-old female patient
Yes.
complaining of diplopia,
Mm-hmm.
subacute diplopia, confusion, headache, and right eye gaze on a palsy on examination. Go on.
Okay. Thank you. So I'm presented with multiple sequence MRI sequences of the brain. I'm going to scroll through these sequences first before presenting my findings. I'm looking at the T2 axial slices. Okay, so the first thing I see is a high T2 signal intensity of the medial aspect of the left temporal lobe. I'm going to go scroll through the rest of these sequences. This is also a high T2 signal on flare. I'm going to check if this enhances, and it does show some mild enhancement. There's also some enhancement seen in the right basal ganglia. I'm going
Okay.
to focus on the left temporal lobe, looking at diffusion restriction. So it is high signal on the DWI, and it does show diffusion restriction. Looking at the PD images as well on the sagittal. I can't see any other signal abnormalities. And to conclude with the axial PD, there's the high signal on the left temporal lobe. So in conclusion, there is a signal abnormality in the medial aspect of the left temporal lobe, which demonstrates diffusion restriction. Given the presentation and the findings, I would suspect that this could be infective or inflammatory in nature.
Doctor, 1 second. 1 second. You talk only about this medial left temporal lobe. What about the rest?
So with regards
What
to
about
the rest
what
of the
about
scan,
this? What about this?
there's high T2 signal in the basal ganglia bilaterally in the
Yes.
caudate heads and
Yes.
the putamen. So this is most in
What else?
keeping.
Yes, yes.
Um, there's
Not only see,
also
see, doctor, not only the left side, also the right side and the caudate. And what is this?
so this is the posterior internal capsule.
Okay. So you are dealing with a multifocal signal abnormality, not only left sided. Okay.
Yes, yes, yes. So
Hmm.
multifocal signal abnormality, it is
Hmm.
it appears to be asymmetric, and in this instant, my differential diagnosis for this would be gliomatosis cerebri,
What else?
um, an infective inflammatory. Other differentials could be even 65-year-old patient. It could be herpes simplex encephalitis, um,
What else?
and
But do you remember the history?
yes, so she is complaining of um, diplopia, eye
Yes.
symptoms.
Do you remember the onset? I mentioned the onset.
Was it sudden in onset?
No. Subacute.
Subacute. Okay,
Yes.
so this is not an acute finding. It has been
Yes.
gradually going on. I would think that this could be glyomatosis cerebri. It could be a demyelinating process such as ADEM. Given the eye
Okay.
symptoms, it could be a neuromyelitis optica, although I would expect to see signal changes in
But one
the.
second. One second. Do you
Mhm.
think neuromyelitis optica is very common to affect the basal ganglia? And
No,
see, 1 second. The mesial temporal. By the way, this is called the mesial temporal lobe. The
mhm.
mesial temporal lobe. See, doctor, what is the most common to differential diagnosis of affection of signal abnormality of bilateral asymmetrical mesial temporal lobe in
It
both
would be
sides?
it would be herpes simplex encephalitis.
What else?
And another thing would be limbic encephalitis from paraneoplastic causes.
Thank you so much, doctor. This is the point. You should concentrate. Thank you so much. You did very well. You should concentrate on your pathology side. It is
Mhm,
bilateral, asymmetrical, involving both mesial temporal lobe, postcaudate, perifrontal, okay,
mhm,
and here in the basal ganglia at the right side, and see here in the medulla, okay. So we are
mhm,
dealing with multiple scatter signal abnormality, mainly in the mesial temporal lobes and basal ganglia. Your differential diagnosis should be within 2 or 3 maximum pathology. Number one,
mhm, mhm.
viral infection or herpes. Number two, because see the age,
Yeah.
65, and then there are no fever, and the onset is not acute. It is, see my colleagues, see,
Mm,
very critical. Subacute, old age. You should put paraneoplastic syndrome at your top Differential diagnosis.
Mhm.
Okay. What is the cause of paraneoplastic syndrome? What is
Lung
the common
cancer,
cause and what else?
breast cancer, um,
Okay, not common. يعني breast cancer is not common. Which type of lung cancer is very common in paraneoplastic?
bronchogenic carcinoma or
What type? Yeah, a
small
small cell.
cell, yes.
Small cell. That is why they now they differentiate any lung cancer either small cell or non-small cell. Despite the small cell is low percentage, but it is very important due to its paraneoplastic syndrome. Doctor, could you tell me the pathology behind this paraneoplastic syndrome?
Um,
This cancer secretes something. Do you know the name, the material?
I don't remember it, sorry.
Okay, don't worry about it. Perions. Perions. This perions is a trigger against the neuronal cell of the brain. Okay, so it
Mhm.
causes this type of demyelination. Perions. What is the management of this paraneoplastic syndrome or this patient?
So this patient is she's going to need investigation to look for a primary. So she's going to
Okay,
have at least a
what
chest
else?
X-ray to start with,
Okay,
referral to chest MDT for CT and CT abdomen pelvis as
okay.
well.
For the brain it changes.
For
What do
the
you
brain,
expect? What do you expect the
um,
management?
so she is going to need a neuroaxis imaging. Um,
Okay, okay. See, this is a type of demyelination. What do you
mhm.
think the proper treatment? Very common treatment in demyelination.
Steroids.
Yes,
She's going
thank
to
you so
receive
much.
steroids.
Thank you so much, doctor. Very well. My colleagues, this is a case of paraneoplastic syndrome. How to differentiate from viral or herpetic encephalopathy or encephalitis by number one, by the onset. Number two, is there are fever or not? Number three, I think the paraneoplastic syndrome more scattered, okay, and affecting, see, the brainstem here may be something, and superiorly here, more scattered than the viral infection. Thank you so much, doctor. Next candidate,
Yes, sir.
welcome. Are you ready?
Yes, sir.
This patient has abdominal pain. 45-year-old patient with abdominal pain. Request control, please.
I request.
Go
Uh,
through the image, please.
this is the MRCP images of a middle-aged person with abdominal pain.
Yes.
Sir, is it abdominal pain?
Yeah, abdominal pain.
Okay. I'm not able to scroll.
I think it is a static image, so you can do.
Okay, okay.
You can pick up.
In this MRCP image, I can see a fusiform dilated common bile duct
Okay.
and gall. Yes, sir. Fusiform
Okay. Okay.
dilatation of common bile duct, no evidence of significant intrahepatic biliary radical dilatation. Gallbladder is seen, but no definite evidence of any cholelithiasis. I would like to see the entire images to look for the pancreatic duct as well as its insertion into the amila factor.
1 second. Leave the mouse 1 second. 1 second. Because this is static image, I will help you go through for these images. What else? Look at this image. Well, what happened?
There is in between the uh, gallbladder and the CBD, I'm seeing some soft tissue intensity.
See, doctor,
Hyper.
doctor. This is MRCB. So concentrate only in the biliary tract.
biliary tract. Okay, there appears to be some anomalous origin, means some variant, because like trifurcation of the right and left biliary radicle, it seems.
Okay. You talk about the extra hepatic biliary tract.
Ah.
What happened here?
Intrahepatic biliary radicle.
Yeah, what happened?
There is
here?
mild, some not dilated anyway, but some mild stenosis and some appearing, some bleeding appearance, minimal.
Excellent. So you
But
are
since
thinking
it is not
about what?
dilated, it is subtle.
Okay. You are so. What is your concern?
If it the bleeding of the biliary radicals, I'm concerned about primary sclerosing cholangitis.
Excellent.
Uh,
Let's see the rest. I think
so
this is. You can scroll.
this is the T2 weighted MRI images of the same patient.
Okay.
Gallbladder appears normal. Mm. In the liver. Mm. Primary sclerosing cholangitis, I am concerned about any autoimmune pancreatitis. So in the pancreas, pancreatic duct is not dilated, but the pancreas appears sausage shaped with the loss of folia of the pancreas. So this could be an autoimmune pancreas. There will be association of the autoimmune pancreatitis.
1 second. Look here. See, the pancreas is not bad. See. There are some vegetation here. Correct?
But some low sizing. Okay.
Yeah. And to diagnose autoimmune pancreatitis, you should find the halo sign, not only the sausage shape. Okay. So
Okay.
give me your diagnosis, please.
So it is okay. It should be. It can be a case of primary sclerosing cholangitis. So other associations that autoimmune pancreatitis is not there. Other there is hepatic fibrosis has to be ruled out. But and other autoimmune conditions like I'll be concerned about other conditions associated with primary sclerosing cholangitis like some retroperitoneal fibrosis.
What else?
Then reduced thyroiditis.
What else?
The tumor of the orbit, etc. And IgG association has to be other IgG associated, IgG4 associated conditions. In this
what
case,
else there are some very common inflammatory bowel disease associated with primary sclerosing cholangitis.
Crohn's disease.
Excellent. So what's your
I will
next
look for
step?
Crohn's. So I will scroll. Crohn's disease will be associated with the multiple areas of narrowing of the small bowel with the stricture and ulceration. This image I am not able to. Some areas of narrowing is seen, but I don't know it is some outward narrowing. Maybe could be fistulation. So I would look for the history of the patient also, whether the patient has any abdominal symptoms.
What sequence do you want?
This enterography is MR enterography is
Leave them out.
needed.
Leave them out. Look here. Do you find any clue? Hello?
Yes, yes, sir, I'm looking.
Do you find any clear clue for bronze?
I could not.
Okay, thank you, doctor, so much. This is a case of primary sclerosing cholangitis. When you are dealing with MRCP, please concentrate in the biliary tract. This is not your duty to talk about the soft tissue, the pancreas, and MRCP sequence. See here, marked attenuation and some beaded appearance. But this is very obvious. Very obvious. Okay? Very obvious. And they reduced even number of arboretalization or branching. This is very important sign of primary sclerosing cholangitis. Besides the narrowing and the beading, see here there are positive. Look here, look here, and then this is the common hepatic. If you go down, this is the common bile duct, but the fruit is here. What is the most common association? The doctor enumerated very well, plus the Crohn's disease. Uh, you should comment on the sacroiliac joint here, here. Okay, it looks like not bad. I think no any obvious clue for Crohn's disease in this case. At least to 100 to be 100% sure, you want diffusion and post contrast images. Thank you, doctor, so much. Next candidate.
Thank you.
Hi, Dr. Ami. Hi.
Hi, doctor. This is a 40-year-old female patient with pelvic pain.
I'm presented with an abdominal X-ray of a 40-year-old female with pelvic pain. I'm just taking a moment to scroll to look through the image.
Request control, please.
I've requested control.
Yes.
So I'm just looking. There's nothing. So I can see that there is an increased density seen
Excellent.
in the lower pelvis. It seems to be of soft tissue density.
Okay.
It is placing the bowel medially and superiorly. I would like to follow this up by doing. Sorry, I would like to. So differentials for this could be lipoma. There is other.
Are you sure, doctor? Doctor, 1 second. Are you sure this is could be lipoma?
Other differentials in this case, it could be a soft tissue lesion seen within the pelvis.
Okay. So don't restrict yourself. Soft tissue, whatever. Okay, whatever it will be for further characterization. Okay.
Sure. So I'd like to compare with previous imaging, and if no previous imaging, I'd like to proceed with doing initially a CT of the abdomen and pelvis with contrast.
CT? No, ultrasound first, doc.
Sorry, yes, gynae. Sorry, yeah. Ultrasound. Yeah. So I'm presented with ultrasound of the pelvis, just taking a moment, abdomen and pelvis, and just taking a moment to look through. I can see that there is some hydronephrosis of the left kidney, probably and most likely due to this mass causing obstruction to the proximal hydroureter and therefore causing hydroureter nephrosis, which I would like to inform the urology team to possibly suggest a nephrostomy nephrostomy. There is also a focal echogenic mass lesion centered adjacent to the bladder causing compression. It is relatively homogeneous, well defined with few linear echogenic foci seen within. It is anterior to the rectum and it's posterior to the bladder. It shows acoustic enhancement, posterior acoustic enhancement, and the margins
are you sure, doctor? Are you sure? No enhancement. No enhancement.
Oh, sorry.
What do you want to do next?
I would like to proceed with doing an MRI of the pelvis. Okay, they did a CT. So I'm just going to scroll through these images of CT, abdomen, and pelvis. Sorry, I'm just going to look at. There is hydronephrosis of the left kidney.
Yes.
Okay, I'm just going to see. There is mild bit of fat stranding and some inflammatory change of the sigmoid colon adjacent to the mass lesion centered in the uterus. It shows a focal low attenuation, ill-defined area, suggests possible necrosis, and few foci of air seen within.
Okay.
So this is a uterine-based mass lesion in this relatively middle-aged lady. I'm concerned about a possible. Initially, I'd think about uterine fibroid, which has undergone necrosis. Other differentials for this appearance would be in keeping with a uterine mass lesion.
Doctor, what do you think fibroid will present it with this necrosis and the hydronephrosis?
No, it wouldn't present with this necrosis.
There are very common lesion in the uterus, very common to be associated with hydronephrosis. The only one mass
that can cause hydronephrosis.
Yes.
Okay, in the uterus. So a uterine leiomyosarcoma or uterine leiomyoma, but that's the fibroid, isn't it?
1 second. Leave the mouse. Yeah. What do you think? Where is the mass exactly?
So the mass lesion is actually centered lower down from the uterus. It's probably within the endocervical region, extending inferiorly. So it's a cervical lesion.
This is a case of
cervical malignancy. Yeah.
Okay.
Where
is this? Where is the mass? Which part of the uterus?
It's the inferior aspect of the uterus.
Yes, doctor. There are something very common here in the cervix.
Yeah.
So this is, give me a diagnosis.
So is this cervical cancer with?
Yes. Okay. Which give me the local staging, please.
So you have a FIGO classification for cervical cancer.
Give me for this case. Give me which grade.
2B and above, because I believe there's more than myometrial. The parametrial has been invaded, and it's quite extensive. I'm just looking for any, and there's hydronephrosis, so they'll be stage 4, wouldn't it? Yeah.
Stage. What is the stage?
I would say stage 4.
Okay, and what about this bladder?
It seems compressed posteriorly, and there seems to be some invasion of the cervical mass.
So what's your final classification, please?
It would be stage 4. I believe it would be stage 4. I don't know if it's A or B.
Okay, so this is stage 4. Yeah. Okay, thank you, doctor. What is your next step? Tell me about the management, please.
Urgently, I would like to inform the urology team because there is hydrouterine nephrosis. So I'd like to address that with the nephrostomy. Otherwise, I'd like to discuss this patient in cervical MDT with local staging. To complete local staging, I would like to do CT, and I would like to follow up with staging CT of the CT abdomen and pelvis.
Doctor, could you tell me what type of metastasis of cervical cancer? You told me you will do a staging CT. What is the expected picture of the metastasis of the cervical cancer?
Would it be local regional? So it wouldn't be extensive. I've not seen cervical masses seen in the chest or abdomen in the past.
See,
So I'm thinking,
this is cancer cervix. Okay,
yeah,
cancer cervix. You will do for it a staging CT. What is
yeah.
the expected picture, or what is the expected shape of the metastasis of cancer cervix, especially in the lung?
Oh, would you see cannibal mets, or would you see
No, no,
no? Okay.
no. What is the pathological type of cancer cervix?
Squamous cell. So
Okay, when is squamous cell carcinomas
it would be yeah,
metastasize
yeah,
to the lung?
yeah.
It
Classically,
will,
squamous cell carcinoma cavitates the lung.
yes.
Yeah, that we
So it will give a cavitating metastasis in the lung. And this
yeah.
is very important, my colleague. When you
Mhm.
find a cavitating metastasis within the lung, if the patient is female, tell the examiner, doctor, cancer cervix should be excluded. If he is a male, so doctor, we should exclude any head and neck squamous cell carcinoma, like
I see.
tongue cancer, whatever. Okay.
Mhm.
Thank you, Dr. Anthony, so much. You did very well today, more than
So
yesterday. Trust
gynae
in
is the
yourself. Trust in
worst.
yourself.
Yeah.
Yeah, the answer is in your brain. Don't
Mhm.
hesitate, please.
Sure.
My
Thank you.
colleague, see, leave the mouse, please. Tape. See, this is an extensive cancer cervix. See, it is almost bulging within the bladder. No muscles here of the bladder is intact. Okay, see how to examine the cervix of the uterus. Come from down, from the anus level, up. The cervix should be a smooth ring, not like this. Number two, it should be dark in T2. Okay, my colleagues, this is very important. Why? This cancer is very huge, so it is very easy to diagnose it. But I'm talking about nodule. If it is a nodule, if it is a small, I should see the cervix, يعني, like this, exactly, this size. Number two, it should be dark. Why? Because the cervix contain either some muscles and fibers. So it is dark, not bright. If you find something, see here, it is relative bright here. This is the mass. If you find in the cervix any high T2 signal, both cancer cervix until proof otherwise. Okay, this is an extensive stage 4 at least, because it invades the bladder. Okay, and invades the parametrium, and see the ureter. See the ureter. When the cancer cervix invade the parametrium, it is stage 3. Okay, when it is cause a hydronephrosis, okay, it is also, we are in stage 3. But when it is invade the surrounding like the bladder, stage 4. Stage 4. And there are some talks about the staging, if it is involving the upper part of the vagina or the lower part of uterus. Okay, this is yeah, less important than being invading the local structure or the ureter. Thank you so much, doctor. The first line of treatment in case like this is a chemotherapy because it is inoperable. After that, they will assess how to remove the uterus and everything. But if you asked, if you were asked in the exam, what is the first line of treatment in case like this? Number one, chemotherapy. Why? To debulk, to reduce the size of this huge cancer cervix. Okay. Uh, this is understandable that our first step is to put a nephrectomy. This is understandable. The doctor has mentioned, but I'm talking about the cancer itself. What is the first line in huge cancers? We should give chemotherapy. to reduce the size of cancer. Next candidate.
Thank you. Thank you.
Welcome. Next candidate.
Yes, sir.
Welcome. Request control. 40-year-old female patient presented with fever and diarrhea.
Okay. I have been provided with a frontal radiograph of an abdomen of a patient who is presented with a complaint of fever and diarrhea. Looking at the radiograph, I can see there is there is some evidence of loss of air in the left side of the colon. I could not see the air on the left side of the colon with um, some abrupt narrowing, and apart from that, there is some thickening of a hostra noted in the region of the transverse colon, giving a thumbprinting
Excellent.
appearance.
Excellent.
And also their thickening is also extended into the splenic flexure and also
Okay.
on the also on the right side. So in this
Yes.
patient with history of fever, I'm thinking of colitis. Um, apart from that, I could not find any free air or which could suggest me a pneumoperitoneum, and no any
Yes.
evidence of. I can see there is a evidence of like air is seen on the right iliac region. I can see the bowel loop on the both side.
Give
This
me a differential diagnosis.
this could represent a regular sign. However, to confirm it, I advise the lateral decubitus view.
Doctor.
Otherwise, this is an colitis, so I will go with the
Yes. Yes.
contrast.
Yes. See. If you remember the history, fever and diarrhea. Okay.
Yes,
So now what will you do next?
yes, I will proceed further with contrast and CT scan of the abdomen to rule out the cause.
Can you scroll?
Yes. I have been provided with the axial CT images of an abdomen post-contrast images. Sir, I'm not able to scroll.
Use the arrows. Use the arrows.
Sir, you are scrolling or I am scrolling?
I'm scrolling.
Okay, I have been provided with Excel CT images of an abdomen. Looking at the abdomen, I can see there is a diffuse thickening of the wall of the colon is noted, associated with adjacent fat stranding involving the left side of the colon, also on the right side of the colon. This is extending downward. There is a significant thickening is noted in the region of the sigmoid colon with adjacent fat stranding. So I'm looking for the cause. This can be due to inflammatory, infective, or due to ischemic. I would like to see the vessels, if there is any thrombosis within the vessels.
Do
The
you
SMA
think,
appears.
Doctor, 1 second, do you think the ischemic colitis can be pancolitis like this?
No, no, but as patient is present with fever, the likely is infective colitis. Other
Okay.
differences for this ulcerative colitis.
Okay.
So in my routine practice, I will also look the other association of ulcerative or colitis to see the sacroiliac joint.
Excellent.
However, I could not find any collection or any free air, and there is a diffuse thickening. The SI joint appears to be narrowed. I will confirm it on the bone window, however.
Okay, doctor, what is your next step?
Yes, so I will convey my finding to the referring physician. This patient, there is a lead pipe appearance on the left side of the colon, which confirm my finding of ulcerative colitis. So I will convey my
Okay.
finding to the referring physician, refer this patient to the gastrointestinal MDT, and also rule out other association of a Crohn's disease like a gallstone, which I could not find in this case. Also primary sclerosing cholangitis, which is also I could not find in this case. and refer this patient to the gastrointestinal MDD for maybe this patient require colonoscopy and biopsy and further antibiotic treatment and maybe steroid for further management.
Thank you, doctor, so much. You did very, very well. This is a case of pancolitis. Look at the colon, all the colon. So, but the most important, you pick up here, the X-ray. See the second Auster. My colleague, I give you some bit of advice here. The outer surface of the colon, the name here is haustra or haustration. But here, this is hauster fold because it is a little bit confusing. So this is a haustral fold, but the outer surface for it here, the haustration. Okay. Here, what happened? Thickening, giving the fingerprint appearance. Okay. Thickening. Very obvious where in the transverse colon. Okay. By the way, the sacroiliac joint, doctor here is healthy. Okay. Normal. No any problem. So our doctor asked for CT. For CTC, pancolitis. So in pancolitis, don't put ischemic colitis. Yeah, if you want to put at the bottom of your list. Okay. Number two, the vessels is intact. So exclude. Absolutely, you can exclude the ischemic colitis. So we are dealing here with pancolitis. It's either infectious or inflammatory. Okay. I think the CT here is there are no obvious clue to exclude one of them because the inflammation here is extensive and cause obvious significant neural thickening and enhancement. Okay, it is a little bit give yeah, pipe steam maybe, but better to say, Dr. Roshni here, loss of the haustration. Better. Okay, because a biped appearance is a chronic sign or a chronic or a sign of a chronic ulcerative colitis, and actually we are not sure about the diagnosis here. There are no clue why the sacroiliac joint is normal. The number one. Number two, the patient looks like from the history with acute. See, acute 1 week diarrhea and fever. Looks like infectious from the history. Okay. From the CT, it is a borderline 50% infectious, 50% ulcerative colitis. So better both differential diagnosis. Don't be definite in borderline cases. You did very well when you talk about your beyond the case, and this is very, very important. What will you do to rule out other associated diseases or complication like biliary tract problem, like sacroiliac? Very nice. Thank you so much, doctor.
Sir, I have a question. On the radiograph, is there any regular sign or it is just because of fat?
No, nothing. Where? No any regular sign.
Sir, on the right iliac fossa region, on the iliac crest, I can see the both wall of the bowel loop.
No.
Okay.
No, at all. I think here because the wall is second.
Okay.
So it is very prominent. Okay.
Okay. Thank you, sir.
Thank you. Next candidate.
Hello. Hello. Yes, I'm here.
Hello.
Hello. Can you hear me?
Yes. Request control, please, doctor.
Okay. Just a second. Okay. I did request the control.
70-year-old female patient for follow-up. My colleague, by the way, GIT, in my opinion, is the most one, and it is the most important and the most difficult because it contains endless pathology, and the GIT itself contains many organs. I think I said this advice before. So my advice to you, you will find at least one case in the long reporting. It must be GIT. Okay. Second, in the short, you will find many X-rays of the abdomen and the many GIT. Third, in the Viva, at least you should be presented with 2 to 3 cases, at least. Okay? So my advice to you, concentrate a little bit in GIT. I made in my YouTube, I think about three long sessions about GIT. 3. You can find it. It will add many benefits for you. Doctor, this patient came for follow-up. This patient, again, 70-year-old female patient for follow-up at the clinic. Can you scroll, please?
Okay, just a second. I think I'm not able to scroll. I think.
1 second, 1 second. Use the arrow.
Okay. Okay, yes, I can. So I'm presented with this is a non-contrast phase of CT abdomen of the 70 years old female presented with the follow-up. So I'm just having a quick look from the first to the last cut, and then I'm going to give my comments.
Okay.
Okay. Sorry. So I'm sorry, I have an issue with the scrolling, so I'm so sorry about it, because I think it's the touchpad that's the issue. So yeah. So I can see in the pancreas there is a cystic lesion seen at the head of the pancreas, as well as in the body.
Go on.
Sorry?
Excellent.
Yeah, so I cannot see any fat stranding related to the pancreas or the peripancreatic region. I can see there is also a gallbladder stone. Looking at the heart, it looks like she have a dual lead pacemaker with the leads in place. So I would also need to look at further contrast to just identify these lesions. So can I just look at the other sequences?
Yes.
Okay.
Okay.
Okay. Okay, so this is the arterial phase. Okay. Okay, so there is a cystic lesion in the body of the pancreas. I cannot see a definite enhancement within this lesion, and there's another one as well, and also there is the other one at the head of the pancreas. I'm looking at the CBD. The CBD is not dilated. The pancreatic duct itself is not dilated, and the pancreas is not atrophied. It's just, I mean, it's like it's the atrophy which is accepted for the age of the patient. So I will also look at the rest of in my usual practice, I will look also at the rest of the sequences. Since this is an arterial phase, so the patient will probably have a complete venous phase. So this is the venous phase. I'm looking at the liver. I cannot see any suspicious lesion. I'm trying to look at the vessels.
Where is your main pathology, Dr. here?
The main pathology is, I have a problem with the scoring, that's why this is the issue, but the main pathology is in the liver. There is multiple cysts at the liver. I'm trying just to see the relation.
No. Liver?
Sorry, the pancreas, I'm sorry.
Okay.
Yeah, the pancreas.
I will help you. This is a pancreas.
Yeah, please. It will be great if you have.
Okay. You didn't see why I didn't help you. You didn't request, and this is the style of the exam. Request, I will give.
Okay. Yeah. So actually, there's multiple cysts. Like there's a cyst in the tail as well. beside the body and the head of the pancreas, I cannot see a direct relation with the vessels, and the vessels are opacified normally. The pancreatic duct, there is no like
Doctor, look at the neck, please. 1 second. There are
the neck.
cysts at the
Yeah, and
neck.
actually, I can see a cyst, and it looks like the duct could be communicating to one of the
Yes.
cysts. Yeah.
So ask the examiner either, Doctor, I wanted to zoom. Why? I wanted to rule out communication. Or
Yes.
Doctor, I want to MRI to
Yeah.
MRI and MRCP like this. Okay. So
Okay.
what happened here?
When zooming, I think some of the cysts actually are communicating to this to the pancreatic duct, which is actually not dilated. So so my differentials will include an IPMN.
Yes.
And in my usual practice, I will look at the previous study synthesis and a follow-up to see if this lesions is progressing or they are stable, and I will notify the referral with this finding. And if there's a progression in this, like the size of this cyst, and this patient will need to have a tumoral marker correlation, and also she will benefit for a further MRI to exclude any further progression.
Thank you, Doctor. Amazing. Really amazing, amazing. Why? Because as I told you many times before, the pancreas is a big problem, especially in old age. But why? Because it is almost 70-year-old. It's almost atrophic. And here what happened? Some cysts, most of us will consider, okay, doctor, this cyst is cyst, simple cyst. Okay, but look here, look here. Follow,
Yeah.
please concentrate, all of you, please, in the neck. I will make it very zoom. Concentrate here. See, this is the cyst. Then, see, see, this is the duct, and this is the communication here. So, see, this is the duct. So the cyst, see, this is the duct. The cyst is communicating. At least this cyst. Okay, we should follow cyst by cyst. Okay, no problem. But at least we pick up one of them communicating. So we are dealing with side branch IBMN, intrapancreatic mucinous neoplasm. Okay, and this is very important. This is not a simple cyst. Okay, this is a tumor, and you should do the usual management for your any tumor, like MRI, like doctor. I will request blood tumor marker. I will transfer to oncology like this. But the fruits here in this communication, this one. Thank you, doctor, so much. This is a side branch IBMN.
Thank you so much. Thank you.
Hello.
Hello, doctor. Welcome. Request control, please. Could you request control, please? Yes, thank you.
I have requested the remote control.
No history.
Okay.
This patient.
Okay, these are these are sagittal T1 weighted images of the brain of a
Can you
child.
scroll? Can you scroll?
Okay, sir. Okay. Sir, I think
Yes.
I'm so. Sir, I think I'm finding difficulty in scrolling.
One second. One second. One second. Use the arrow. Use the arrow. Yes.
Okay. Okay. These are okay. These are sagittal T1 weighted images of brain of a child.
Yes.
I can appreciate that there is a large cystic lesion in the posterior cranial fossa.
Yes.
It is likely in the region of the foramen of magnum. I will confirm it on the axial images. There is a thinning of the overlying occipital region in the skull vault. This on the axial. This is on the T2 weighted axial images. Sir, again, it is I think stuck. Yeah. Okay. Okay. This cystic lesion. There is communication of this cystic lesion with the fourth ventricle,
Okay.
and I cannot appreciate midline vermis.
Okay.
And also there I am looking for the ventricular system. The rest of the ventricular system, it shows a mild dilatation.
Okay.
There is focal lesion in the supratentorial location. In summary, in this child, large cystic area in the posterior cranial fossa in the region of foramen of magnum, communicating with the fourth ventricle with Vermian Vermian aplasia. Likely, this is the Denny-Walker syndrome. So I will inform the findings to the referring physician, and also this patient needs reassurance, and the parents needs reassurance in this case. Ventricular peritoneal shunting can be helpful. I also need to.
Okay,
There
but
is
give
no
me,
evidence
doctor, give me your differential diagnosis.
Okay. The other differentials in this case would include a large arachnoid cyst in the
No, I
posterior cranial.
didn't listen you. Give me from the beginning. What's your differential here?
Okay, in summary, in this patient MRI of the brain of a child patient, there is a large cystic area in the posterior cranial fossa in the foramen of magnum, communicating with the fourth ventricle with the Vermian aplasia, and also hypoplasia of the bilateral cerebellar hemisphere. So my principal diagnosis is Randy-Walker syndrome.
Okay. Okay, what is your next step?
So I will inform the findings to the referring physician, will suggest referral to the neurology, pediatric neurology team. Also, parents need reassurance. Ventricular peritoneal shunting also may be helpful in this case. As there was a small extension, there was dilatation at the craniocervical junction. So likely whole of the neuroaxis is suggested. And the patient parents needs reassurance, and further screening can be done.
Okay, thank you, doctor, so much. This is a classic case of Dandy-Walker malformation. As you see, large posterior fossa cystic structure communicating with the fourth ventricle. Okay, associated with supratentorial ventricular dilatation. Okay, this is a Dandy-Walker. Sure, we can't see the vermis or tonsils, and associated also with hypoplasia of both cerebellar hemispheres. This is a classic case of Dandy-Walker. What is your next step? Number one, VP shunting, because there are hydrocephalus here. Number two, neurosurgical pediatric intervention like this to repair this. They remove, I think they remove this cyst, and they make something to decrease the pressure. Thank you so much, doctor. Next candidate.
Thank you, sir.
Assalamu alaikum.
Alaikum salam. Doctor, can you request control, please?
Sorry, I don't have a mouse and I'm on mobile.
No problem. This patient presented with fever.
Okay. I have been presented with frontal chest radiograph for an skeletally mature patient with history of fever. After reviewing the radiograph, I cannot see any obvious abnormality, so I would go through my checklist. I can see that there is on the left retrocardiac shadow, I can see that there is density seen retrocardiac area. In my routine practice, I will change the brightness of this image to confirm if it is retrocardiac mass lesion or not. The other thing that I noticed that there is well-defined nodule versus mass seen in the upper lung zone, right upper lung
Okay.
zone.
Okay.
Otherwise, I cannot see any nodules or lesions within the rest of the lung zones. Both costophrenic angles appears clear with normal cardiothoracic ratio. I am now tracing the bones to see if there is any abnormality within the osseous structures or any missing ribs, which I cannot assess. And as the patient is presented with a history of fever, I am thinking about infectious origin of this radiograph. Uh, I ca-
Yes.
in my routine in practice, I will combine my funding to the referral doctor, and I will arrange for chest CT scan for better evaluation.
Okay. This scan.
Yes. This is the axial CT scan images, chest CT scan for the same patient with IV contrast. I can see that there is multiple scatters, soft tissue lesions seen at both lungs. I want to see the lesion on the right lung. Can we scroll down a little bit? Yes, I can see that this lesions looks like ground glass and surrounded by consolidation, giving the appearance of reverse halo sign, which is also called atoll sign. My differential diagnosis for this pathology, it could be due to cryptogenic organizing pneumonia.
Doctor,
In
one
this
second.
case, I want.
One sec.
Yeah.
Where is the atoll sign? Where?
I think I saw one on the right upper lung lobe.
Okay.
It's not.
This
Yeah,
one? This one?
the large one. Yes, yes.
What happened
It's
there?
look
Tell
like.
me. No. Tell me.
Yeah.
What happened here? Why
I
you
think that
mentioned
is
this atoll sign? Why?
because I can see that there is central ground glass appearance, which is surrounded by consolidation.
No, doctor. See, this is a mass or a consolidation, and outside the mass there are ground glass. What you see in the
Okay.
center here, not a ground glass. This is something else. Could you tell me what is this in the center?
It could be due to necrosis.
Okay. So what
Yes.
type? What is the type of this mass?
Necrotic mass lesion
Cavitary
with
nodule.
surrounded
Okay, cavitary
cavitary
nodule.
nodule. Yes.
Okay, so
Yes,
give me
cavitary
differential
nodule. Yeah.
diagnosis.
Because if the patient is presented with fever, at the top of my list, I am thinking about tuberculosis. In this case, I will urgently confine my finding to the referral doctor, isolate the patient, and screening the contacts and relative of this patient. Other differential diagnosis, if the patient is known case of um, a primary tumor elsewhere, I am thinking about cavitary metastatic lesion. Otherwise, I am thinking about, because the history of the fever, other atypical infections such as fungal infection or atypical pneumonia.
What else other than fungal infection?
Um, I can think about abscess because abscess can cause cavitary lesion and presented with the history of fever. It could be due to collagen disease or connective tissue disease, such as rheumatoid arthritis can cause cavitation lesion and also
Okay, but see, doctor, one second. The distribution here is peripheral. Peripheral.
Yes. Yes. Yes.
Is this possible in rheumatoid? Peripheral.
No. No. No.
What does it sound for you is a peripheral distribution? What is the significance? All of them
Yeah.
is a
Vascular.
peripheral.
It could be due to vascular in origin.
No, not vascular in origin. You are very near. It is blood-borne.
Blood. Yeah. I mean vascular, blood-borne. Yes.
Blood-borne.
So.
Patient.
Yeah. Blood-borne.
Yes.
So I was thinking about septic emboli because
Yes. Thank you,
septic emboli
doctor.
is blood-borne and
What is
it
your
can cause
next
cavitation.
step? What is your next
My
step,
next
doctor?
step for this patient, I will see if the patient is a drug abuser or not.
Excellent.
Second, I want to do echo to rule out any infective
Excellent.
endocarditis.
What is the first line of
Third,
treatment?
in septic emboli, I will give a painkiller, IV fluid, and oxygen.
What else, doctor? There are something important.
Thrombolytic agents.
Doctor, this is septic emboli. You don't.
Antibiotics.
Yes, antibiotics. Thank you, doctor, so much. This is a case
Thank
of
you, sir.
septic emboli from the CT. Why? See, my colleagues, this is a peripheral location. Very suggestive. Second of it, most of them surrounded by ground glass. Most of them surrounded. This is not at all sign. Why? At all sign is the reverse halo sign. See here, the center contain a solid component or consolidation. The periphery contain ground glass. Why? What is the value or what is the pathology under this ground glass? What do you think?
It is infiltrative, which means it's go within the interstitial of the lung, so that the ground glass.
No, nothing else. When something infiltrate, you're talking about the mechanism of ground glass in metastasis. Okay, but ground glass is due to something else. What could you say?
It could be due to bleeding or hemorrhage.
Yes, because of hemorrhage. Okay, because of hemorrhage. Okay, ground glass is common in infection and metastasis. The center here is cavitation. So when you find even one cavitating nodule, tell the examiner this is multiple cavitary nodules or cavitating nodules. Don't set the term cystic changes in chest X-ray or even CT. Why? Cavitary or cavitating. Okay, my colleagues. Thank you, doctor, so much. The first line of treatment here. Number one, to rule out the cause. Either he is a drug abuser or not. Number two, to give antibiotic. Look here, my colleagues. Right upper lung shows a cavitary nodule here. And there are another one here. At least you can detect two. And I give you a history of fever. So you can ask really a CT scan. Thank you, doctor, so much. Septic pulmonary emboli. Next candidate. Hello. Sam. Request control, please, doctor.
Yes, sir. I requesting control. I've requested, sir.
Go on.
Okay. These are T2-weighted MRI X-ray images. Sir, I think you didn't give the history.
Yes. so I shut mouth. If the examiner didn't give the history, please ask. Please, even ask about the age. Very important. Okay. This is 26-year-old female patient presented with abdominal and pelvic pain.
Okay, this is MRI T2 weighted image plane in a patient 26 years old with a history of pelvic pain, abdominal pain. I will take a moment to scroll to go down till the last cut. So that's it. Yes, it's up till this level. In this MRI image, it is getting stuck. I'm not able to appreciate anything up till now. I will take a look once again. There is liver is slightly enlarged, a bit hypointense relative to splenic parenchyma. Both breast shadows are normally visualized. So there is there are prominent intrahepatic biliary channels. CBD is not dilated. Pancreas is normally visualized. So based on this alone, I'm not able to conclude anything yet. Just that liver is a bit hypointense and there are some dilated channels. In this coronal image in the same patient, the uterus is bulky. There are few nodes seen in the superficial inguinal region. There is hyperintensity seen within the uterine cavity.
Okay.
This.
Okay, what else?
There are prominent parametrial
One
vessels.
second, doctor. 1 second, I will help you. Look here, please. What happened here?
This is uterus in T2 weighted images, uterine cavity. There are two uterine cavities. I would like to. Yes, there are two uterine cavities. One of them is here. I would like to see their lower extent. Are they? So there is a single cervix.
Okay.
And on the T1, one of it was having hyperintensity within the lumen.
Okay.
The ovary is normally visualized. So this is the right ovary. I'm thinking in the lines of that there is some uterine abnormality with might be hyperintense component within one of its lumen. So might be one of the cavities is not having outflow connection. So can I see any other plane like sagittal?
Take whatever you want.
Okay, this one.
Doctor, you talk about two uterus and one cervix, correct?
Yes, sir.
So give me first what's your concern. Tell me.
Sir, my concern is that it can be uterus didelphys or bicornuate uterus. And secondly, I would also like to see the kidneys once again.
1 second. You told me you find one cervix. So
it can be bicornuate unicornis.
Okay. You are in the correct pathway. And what else? Compare both uterine cavity with each other. Are they similar?
No, sir. One of them is prominent with internal hyperintensities, and the other one is relatively smaller.
So give me a differential diagnosis at this point, please.
Up till this point, it can be bicornuate uterus with
Yes.
a single small horn.
Yes. One of them is rudimentary or smaller. Very good. This is
Rudimentary,
a
yes.
uterine anomaly. And I give you an abdominal pelvic MRI. What should you search for?
I should search for that. Is there any associated hematometra with the smaller horn? And I should also look for.
Doctor, don't worry about the uterus. At least you give me a good clue. Why the examiner will give you an abdominal and pelvic MRI? This is not logic. But if I give you abdominal and the pelvic, you find anomaly in the pelvis. So your next step to search about anomaly where?
Kidneys.
Yes, in the abdomen. This search in the kidneys or besides the kidneys.
Okay, sir. I will try to go. No, not DWI. Sorry, T2. Once again.
Okay.
So I'm trying to look for any associated abnormalities in the kidneys. Once again, there is somewhat prominent pelvic calyceal system on the left side. The associated anomalies can be duplex kidney or malrotation.
Don't worry about the kidney. What else?
What else? Sir, I don't think it can be. I don't remember any other association.
No. See. There are anomalies. There are another anomaly. Please try to pick up it.
Sorry?
Look here, doctor. Here. What happened?
So there is some hydronephrosis in the left side
Don't
only.
worry about the kidney.
Don't worry about the kidney. Okay.
Yes. What happened here? Here. In this slice.
In this slice. Just anything in. So can you scroll a bit up more? I'm trying to look for the spine.
No. At this slice, look at a retroperitoneal organ.
Sir, there is. I'm trying to look for any vascular abnormalities.
Look at the pancreas, please, doctor.
Pancreas.
What happened?
Sir, I can appreciate the head and body, head and neck region, but the tail is atrophied and somewhat replaced by fatty tissue.
No tail at all.
No tail at all. Yes, there is only head and uncinate process and neck region seen in this current slice.
So, give me your diagnosis, please.
Sir, I would like to see on above and lower down images that if there is any ectopic pancreas associated in the current based on the current image only.
No ectopic. Give me final diagnosis.
So this is bicornuate unicollis uterus with a rudimentary horn and the dilated other horn and with partial agenesis of pancreas and some prominent hydronephrosis on the left side.
Thank you, doctor. This is not hydronephrosis. This is extrarenal prominent pelvis. Thank you so much.
Okay. Thank you so much, sir.
My colleague, will the examiner give you abdomen and the pelvis MRI? There are some things. Don't take it easy. He will not give you. Do you know in the exam he gave you almost 1 or 2 sequence. Even in CT, axial. Most of the CT, he gave you axial and limited study. He wants from you something in his brain. Either you will tell or not. No time to too much scrolling, posting like this. Okay, this is the first one. Second point, this is the pancreas here. Take care, my colleague from the pancreas. Take care. See, you can see only near the head only. Head and ancillary process. Rest of the pancreas, including neck, body, tail, not visualized. So this is dorsal agenesis of the pancreas. When we go to the pelvis, look here, here. This is the cervix. As I told you in the one of the previous case. From down, this is the urethra. This is the anus. This is the vagina. Go up. This is the vagina. Up. I'm still here. Up. This is the cervix. Cervix, there are one cyst in the cervix. Okay. Then see, this is a uterine cavity, and this is another uterine cavity. Okay. Two uterine cavity and one cervix. Okay. This is the bicornate.
Okay.
In my opinion, this is bicornate uterus. Okay. But see the answer here. Unicornate uterus with contralateral alimentary horn. How come? I think it little bit not a logic answer. Okay, but anyway, if you tell the examiner these details, he will pass you. No problem. Okay. Thank you, doctor, so much.
Thank
The
you
answer
so much, sir.
again of this case, my colleague, this is, in my opinion, this is a bicornate uterus with rudimentary horn. Okay, plus dorsal pancreatic agenesis. Thank you, doctor, so much.